Hello, fellow hospitalists, and welcome to Documentation Talks with Dr. Tom. As always, our purpose is to help you get credit for the great work you are already doing, and also to help you avoid queries. In other words, we want to help you document like a genius. Today's topic is myocardial infarction. An elevated troponin can present a clinical as well as a documentation conundrum. When confronted with an increased troponin, the first step is to determine if the patient has had a myocardial injury because of reduced or occluded coronary artery flow. In other words, an MI. Or alternatively, determine if the patient has an elevated troponin as a result of an etiology not related to coronary flow, such as renal disease, sepsis without shock, intracranial hemorrhage, RV strain, PE, heart failure, myocarditis or pericarditis, chest wall injury or CPR. These patients should not have MI documented, but rather non-ischemic myocardial injury. Be sure to link to the cause of the injury. As an example, acute myocarditis causing non-ischemic myocardial injury. Now, for patients who do have signs and symptoms of an MI, it is important to distinguish between a type 1 MI and a type 2 MI. First, let's talk about type 1. These are the patients who have coronary artery disease and experience coronary artery occlusion. In other words, a STEMI or an NSTEMI. Correct documentation requires indicating a type 1 MI, STEMI or NSTEMI, and supporting clinical data such as EKG changes or an elevated troponin. Type 2 MI is a myocardial injury based on a mismatch between coronary blood flow and the demand of the myocardium for oxygen. It is based on physiology other than coronary artery occlusion. You are all familiar with the potential etiologies for a type 2 MI, such as hypoxemia, acute blood loss anemia, coronary vasospasm, shock, and tachycardia or bradycardia. Documentation of etiology is always required. In addition to documenting type 2 MI and the etiology, also document evidence for the myocardial injury. For example, typical symptoms of an MI, ischemic EKG changes, pathologic Q waves, or imaging evidence for ischemia or a new infarction. Complete and accurate documentation for an MI includes these two examples. First, Mr. Smith is a 74-year-old male who presented with crushing substernal chest pain and an elevated troponin. His EKG showed ST depression in 2-3 and AVF. The impression is type 1 MI due to NSTEMI as well as coronary artery disease. Next, Ms. Jones is an 88-year-old female who presented with shortness of breath and transient substernal chest pain, atrial flutter, and tachycardia. There were no ischemic EKG changes, but troponins did become mildly elevated. The diagnosis is atrial flutter with RVR, with the resulting type 2 MI from demand ischemia. Now for a quick recap. When your patient has an elevated troponin, make a clinical determination if it has been a myocardial injury based on the interruption of coronary blood flow. If not, then document non-ischemic myocardial injury as well as the etiology. But if there has been an MI, document the type 1, STEMI or NSTEMI, or type 2. And always document supporting signs and symptoms as well as the etiology for type 2. So long, hospitalists, and stay tuned. In February, for our hospital medicine grand rounds, we will cover why your documentation is so important. And after that, we will be covering a number of additional important topics, such as pneumonia and respiratory infections, how your documentation helps our hospitals meet common spirit health quality goals, and also how to avoid CMS penalties. Thank you for listening, and we'll see you again soon.